Today's podcast guests are Meesha Dogen and Rob Philibert, co-founders of Cardio Diagnostics, developers of a cutting-edge new test for assessing the cardiovascular risk of patients over age 35. They were kind enough to engage in a deep discussion on their new test, and hopefully you'll get as much out of it as I did. One quick note, because all three of us had already read the studies, we did not spend much time describing the background details of those studies. For that reason, I interrupt the podcast in the middle to describe all the studies and catch you up so the discussion is more understandable. With that in mind, let's proceed. All right, so I am here with Rob and Meesha. I appreciate you guys coming on. You guys can introduce yourselves to the audience and let them know where you stand in the company and so forth.
All right. Well, I'm Meesha Dogen. I'm one of the founders and the CEO of Cardio Diagnostics. Wow. Looking back, over 15 years ago, started in epigenetics. I'm sure we'll cover that today. 12 plus years ago, started in AI and machine learning. Formal training, doctorate in biomedical engineering, so engineer through and through, and founded the company in 2017. Led the company since. I like to say I've been the janitor and the CEO, so end-to-end of everything. Yep, everything that's required. Co-invented the technology with Rob. I was essentially my doctoral work that we patented and founded the company on. Happy to be here and looking forward to the conversation.
Awesome.
Yeah, the same. So my name is Rob Philibert. I have an MD, PhD. Did my MD, PhD at the University of Iowa. Completed my residency. I'm actually a board-certified psychiatrist. And then I did 6 years in the Human Genome headquarters in Bethesda, then came back to Iowa. And I really started getting into epigenetics in 2005 after I lost a bet with a seminal figure in psychiatric genetics. And 2008, a brilliant young college student walked into my lab. And together we began our studies, initially of smoking and then drinking. And then she made the bold proposal to do not only her undergrad and master's in the laboratory, but do her thesis project in the laboratory. And I think that that thesis led to the foundation of Cardio Diagnostics, and I think truly a revolutionary technology for diagnosing and managing cardiovascular disease sprang directly out of that thesis, which I think probably could be labeled the best thesis ever.
Not that you're biased or anything there. That's completely objective opinion. I appreciate that. So yeah, I wanted to start this off in a bit of an unusual direction, and we've given some hints here, but let's not go too much more into depth. It is a really cool test. It really is. But let's pretend that this is how the test works. Is you guys have in your lab a wizard and a cat, and the wizard waves his wand over the blood sample, and the cat meows at a particular decibel. And the louder the cat meows, the higher the risk is of cardiac disease. Okay? Now, it's as a percentage. So it's a 0 to 100 decibels. That's the way the cat meows. Now, how do we know that this wizard and cat are reliable? I know you guys have done a bunch of validation tests, and maybe you can walk through some of the data that indicates that your wizard and cat are reliable folks.
Wow. You spoke exactly to the heart of who we are. And, I tell a lot of people, cardio was not founded, we didn't found cardio and then turn around and say, how do we make the science fit? We started with the science and technology, and it was so compelling that we founded the company. And, we asked a very similar question. It was right around 2015, 2016. And at that time, we had done a lot of foundational studies in epigenetics, especially and into AI, and looking at genetic and epigenetic markers. And we asked the same question. When we did the first set of studies and the data looked so good, we stopped, we looked at each other, and I remember Rob said, it looks so good, we have to disclose this to essentially the research foundation for them to take a look whether there's a patent. And me on the other side, I was like, I just want my PhD. And we were right at that juncture. It's like, it looks so good. Is it too good to be true? And so we had to take the next set of steps, because we come from a world of academia, and science is not about truth. It's about reproducibility. And so that's the question we ask. Given that we've seen what we've seen, is this reproducible, right? How can we validate this? And the initial studies were done in the Framingham Heart Study data. And everyone knows the Framingham Heart Study data. It's sort of the gold standard data when we're thinking about heart disease. And it looked so good, we said, okay, who can we find who has a similar data set, a biobank that is similar to Framingham Heart Study, so we're not veering off too much and we're able to validate what we saw. And at that time, we had looked at coronary heart disease, given that it's the leading cause, the most common type of heart disease and the leading cause of heart attacks. And we thought, great place to start. I come from a family with 2 generations history of heart attacks specifically. And it resonated with us. And so we were like, let's go look for someone else. We looked high and low for different organizations that had biobanks and data, and was very fortunate to meet Intermountain Healthcare at an American Heart Association conference. And we were talking to them, and we told them what we had found. And we said, we're looking to replicate what we did. We want to take the proof of concept and we want to take it a step further. Do you have what we're looking for? And they essentially said, we've been wanting to get into epigenetics. That's a whole new world for us. Let's talk. And so I remember Dr. Jeff Anderson, who was the head of the cardiology department, brought essentially, like, was it 4 or 5 cardiologists? And we decided to have a conversation, and we said, let's do the study. They had the DNA. They had the same build out of how we had approached the study, meaning everyone was profiled at one time point and they weren't diagnosed with coronary heart disease, but they went on to have a coronary heart disease event. That was kind of the study design that we were looking at. So we made a deal with them. We started to embark on that journey, and we went on to do the validation study. And that essentially is one of the key publications we put out back into 2021 that shows that we can not only say that the test works well with a set of 8 biomarkers in the Framingham Heart Study, but we can now independently replicate it in a completely different group that was not part of the development process. And that's why the validation came in.
Yep.
And for the next cardiac test, and to use your analogy, not only do we have 2 wizards and 2 sets of cats, we got a 3rd wizard and a 3rd set of cats. And at the core of the technology, though, is precision kittyology. Okay, our cats, we are more than just a company that can take other people's tools and repackage them. In addition to I would really say groundbreaking, and I think truly, I would say next generation AI approach to patient diagnosis and patient management. We bring precision epigenetic tools to measurement. It's important that each wizard be able to distinguish the cats with heart disease from those without heart disease. And to do that, we make sure that we use epigenetic tools that are almost a log order of magnitude more precise than commonly commercially available tools to assess the tone of the cat. So it's very generalizable. We use thousands of cats. We use multiple wizards. And as a result, we have a very robust technology that not only can diagnose cardiovascular disease in men, as been traditionally done, but in women as well, and people from other ethnicities other than Northern European. The goal of the company is to democratize healthcare.
I think that the question in the validations, maybe just let's go through what the validation showed. That as I understand it, that the test at baseline was predictive with a very high sensitivity specificity of the likelihood of heart disease. Is that right? That was my understanding of what the validation showed.
Yes.
So I wanted to break quickly here to catch everyone up on what the test is and how it was validated. Basically, Meesha and Rob got a team together to analyze the genetics and epigenetics of people enrolled in the Framingham Heart Study. They created an ensemble AI and took a sample from the Framingham group who did not have heart disease and compared their DNA and DNA methylation patterns with a sample of people who did have heart disease. That gave them an understanding of what things were likely to be different between those groups, genetically and epigenetically. The AI was tuned so that it would be able to predict, based on who had heart disease and who did not, who was likely to develop heart disease in the next 3 years. This is called the development cohort because that's the group of people that was used to develop the AI. Next, they took what they had learned and looked at another sample of different people from the Framingham enrollees who did not have heart disease and got the AI to predict who would develop heart disease within 3 years. They then looked at what happened to those people over the next 3 years, whether or not they developed symptomatic heart disease, and judged how accurate the AI was. This is called internal validation because it is still internal to the same cohort of people, the Framingham enrollees, as was used to develop the AI itself. They found that the AI in this case was very, very accurate, much, much better than traditional methods like the American Heart Association calculator, which uses cholesterol levels, high blood pressure, and other factors to estimate a patient's risk. But they figured that people who enrolled in the Framingham study might have certain things in common that were unknown unknowns. What they needed was external validation, testing a completely unrelated group of people outside of the Framingham participants. So, as they discuss, they met the people with Intermountain and they took their own AI without any changes and used it to make predictions on an entirely different, separate group, the Intermountain Inspire cohort. They did the same thing as they had done previously with the Framingham group, analyzing a group of people who were known to not have heart disease, and then had the AI make predictions and followed which people ended up developing heart disease over the following 3 years. Once again, the AI outperformed the regular risk factor-based calculators. In fact, they tested whether you could get extra accuracy from combining their AI with the regular calculators, and it turned out that the calculators added nothing or made the predictions worse when compared to using the AI alone. Again, this is interesting because the AI did not take into account the lipids or blood pressure or smoking status, only the DNA and DNA methylation patterns that were seen on the blood sample. So many test makers would stop here, but we still wouldn't really know if we were just finding an accidental association. One way to start looking at whether these were false associations would be to test whether a change in the patient would affect a change in the test results. We know that smoking is a huge risk factor for developing heart disease, but if we could get patients to stop smoking, would we see a change in the DNA methylation and their risk for heart disease as expressed on the test? They tested that idea, and it turns out that you can see a change. This is crucial, as we discussed later on in the podcast. Now, back to the conversation. Let's go through what the validation showed. That as I understand it, that the test at baseline was predictive with a very high sensitivity specificity of the likelihood of heart disease. Is that right? That was my understanding of what the validation showed.
Yes, I think
so
that's... Yeah, go ahead, Meesha.
Mm-hmm. Oh, I was just saying yes. And the whole idea is it's one thing for it to be highly sensitive and specific, which the test is, both tests are. But it's another thing to say, are we doing better than what we currently do today? And I think that was the very critical question, is how does this compare to what we're already deploying in clinical care? And I think that was the next step. So in addition to validation, the next step was, how does this compare to what we're doing clinically today?
Totally.
And I guess, the context I'm coming from is I have a bunch of patients, I have a concierge practice. These people want to be on the cutting edge, and they're listening to people like Andrew Huberman, and they're listening to people like Joe Rogan, and they're listening to these guys saying, oh, you should go test this, and you can test that in your blood and your urine. And it's very difficult to tell which tests are bullshit, frankly, and which tests are worth doing as this new generation of testing comes out that follows different rules, that is done differently. And maybe we can drop the wizard and cat analogy and say, you guys have epigenetic markers that you use an AI to identify, the correct combination of factors that is predictive. But how do we know, and the validation test is really important there, that's how we know that this is not it's not just an epidemiological association, right?
Yes.
Well,
it is causative in some way.
Well, yeah, I would say that put it this way, it's very predictive. I think that's the way we have to phrase it here. But more importantly is, as someone, we are a science first company. We stand in front of our product. And more importantly is we publish everything. We don't hide our product behind a curtain. The data is all the core of the data is based off publicly available information. If anyone wants to check it out, they can more than do so. And we publish what we say. The prior Epi plus Gen CHD has been published. We have shown how the markers regress as a function of successful therapy. And the manuscript that describes this truly revolutionary technology for diagnosing heart disease is well on its way to publication. I think the field will be very pleased, not only with the quality of the tool things, but with the confidence they can have in moving forward because they can see the data themselves.
I think, again, the thing that really swayed me and made me want to talk to you guys in the first place was the study you showed on smoking and smoking cessation. And the reason that was so different to me than what else is out there, and I'm doing another video actually right now on homocysteine, right, which is very predictive, right? But intervening with B complex does not change the risk. It's not in the causal pathway. And so the challenge then, and this seems to be the difference, is not only do you have a test that seems to be predictive, that's a great first step, but then what really opened my eyes was, wait a minute, now if you change something, the risk seems to change. You change smoking, smoking status, which we know is a risk factor, right? And then your test result changes as well. That's acting more like VO2 max, which is also what I do in the office, which correlates quite well with risk as you change the test. And so that got me really excited about this. Do you have other causal pathway tests ongoing?
So one thing I will say there, and then I'd love to talk about precision CHD. I think one of the things we talk to providers all the time is, and this is always an ongoing conversation, what we do today is we treat more traditional risk factors like lipids and diabetes and blood pressure, which rightfully so. We want to manage those and we want to continue to address those. But at the same time, what we're also doing is we're drawing the line between these standard factors and cardiovascular disease, where we're saying, if we have addressed this, therefore we have addressed heart disease. But that's not really 100% true unless we can go now and remeasure heart disease itself and say it has come down. And that's really what we're offering here. It's not just a better tool.
Yes.
It's also a way to draw the line directly to say, are we truly addressing heart disease? But for us, one of the things, going to your point about are we developing products, I mean, heart disease is huge in that there are different types of heart disease. And for us, coronary heart disease was the start, but our patents cover stroke, heart failure, comorbidities like diabetes, and we have other things that we have planned. But one of the key things that allows us to do what we do is, Rob and I talked about our backgrounds and how many years we have spent. And part of that, what we built for cardio is what we call the AI-driven integrated genetic epigenetic engine. What that essentially is years of our work put in a form of a platform that allows us to go from raw data, we start with millions of data points, billions of combinations. Out comes a panel that is highly predictive or of a specific indication. 3-year risk for coronary heart disease was first. We reused that platform for the detection of coronary heart disease. And we're going to go back and reuse that platform for the various conditions, various types of heart disease and everything else. And so what that really allows us to do is use the proven science and technology that we have shown time and time again to work, to continue to leverage it and continue to optimize it. Because at the end of the day, where we want to go is to now be able to pinpoint what are the treatments and interventions that's really going to meaningfully move the needle for me versus you versus Rob versus someone else. And for us to do that, we're then realizing the promise of precision medicine that we've been talking about for many years now.
I think it's interesting, one of the things I always point to with my patients is, I can get your A1C down with insulin, or I can get your A1C down with glipizide. And yet those things don't seem to affect your cardiac risk. Now, if I do it with semaglutide or I do it with metformin in the early days, lesser effect, but significant, or Jardiance, well, those mechanisms of improving A1C seem to also have a cardiac benefit. And so it's important to distinguish that treating diabetes is not a monolith. It's not just getting your A1C down by any mechanism. And it'd be interesting to see whether the different, again, we know that Jardiance reduces cardiac events, whereas insulin therapy alone does not. And so, again, now you guys seem to have created a test where we could meaningfully ask the question, can we tell if a particular medicine is lowering someone's cardiac risk?
Well, and I think your point about the hemoglobin A1C is a very apt one, because with the hemoglobin A1C, we're essentially measuring glycated hemoglobin. Well, glycated hemoglobin isn't part of the disease process. It is an outcome of the disease process.
Yep.
And similarly, why do we measure blood pressure? Why do we measure lipids? Well, to a certain extent, answer is because we can. Okay? It is
That's right.
Lowest
That's
hanging
exactly
fruit.
right.
Now, what instead here is that the power of having biomedical engineers who are very skilled in handling large data sets is that we now have the capacity to take the entire breadth of the genome, and not just the 20,000 genes, but all the regulatory regions, and understand not only to measure them simultaneously, but to study their interaction. So instead of taking a look at a couple serological features that we happen to be able to measure fairly well, we take a very atheoretical stance towards quite literally tens of millions of variables to find which patterns are most predictive of healthcare. And then finally, which is even more exciting, is we devised a way to communicate this to the clinicians and for the clinicians to hopefully communicate to their patients. Because as you spoken, sometimes it's tough to explain very complex things, let alone to other clinicians and to patients. And the actual clinical intelligence platform gives the clinicians the genome view of what is going on at the molecular level, so they can prioritize their patients' therapies appropriately. It's a genetically contextual, personalized approach to heart disease, not all one size fits all. Give them more statins. It's actually targeted towards the individual causes of heart disease.
And you said exactly the causes, and I think that is again one of that causal the cause and effect change really is the thing that opened my eyes. I did a podcast episode on genetics with a geneticist, and he had a great analogy. Is that suppose you have a culture in which the culture believes that all redheads are evil and soulless and must be shunned and scorned and not talked to. Well, if you did a genetic analysis of the genomes of that population, you would absolutely find a genetic correlation between red hair and IQ. Mm-hmm. But that's a reflection of the culture, not the genetics. Now, what's interesting is that if you were able to somehow change the genetic or epigenetic expression, and then all of a sudden something else changed, well, you would then say, well, within this cultural context, actually this matters, and if we can intervene on it, then the outcomes change, right? And so I think that's why I was so excited by the smoking study, is we have pre-existing knowledge that smoking seems to be in the causal pathway of heart disease. And now if you edit that and your test also reflects that change, that gets very exciting, because now it seems to be picking out a feature that's not merely associative. It is, in fact, it does appear to be picking out a causal feature. And that's always why I'm a little bit concerned about genetic tests, is you sample a big enough data set, you can find an association with anything, right? It doesn't mean it's a meaningful one, but you guys seem to have picked out a meaningful association. I'm curious how, the validation studies seem to speak to that, but did you guys have a sense that you had picked out the right interventional features? How did you guys figure out that?
I think to fully understand how we went about it, I mean, for us, it was pieces of the puzzle that we were putting together all along that we didn't realize that was all going to come together. And I think one of the pivotal studies that we did, we published it in 2015, but I think we did it in 2014, was a study that looked at smoking between African Americans and Caucasians. And what we saw was, if both groups are smoking and the biology is same regardless of who you are, we should see epigenetic markers that are identical across both groups. And that's not what we saw. What we saw was there were certain methylation markers that ranked pretty similarly, and others that were way off in where they fell in the ranking as being signals for smoking for African Americans versus Caucasians. And that led us to think, okay, if the information about our lifestyle or environment, in this case smoking, was sufficient, there's no reason why we should see this variation. And that led to one of the core founding or core principle of our technology is the genetic confounding of methylation signal, meaning just because I smoke as someone else from a different genetic background, the effects are not going to be the same, because my genetic background is confounding what's happening to my biology. And so to fully understand my biology, I just can't tell my provider, or as a provider, I just can't say, are you eating well? Are you smoking? All your lifestyle and environment. I have to know, how is that contextual in, or how does it come into context with my genetics? So I need both information. I need to know what I'm born with, which of course I can't change. Thanks to CRISPR, that might change over time. But sure, as it stands right now, it's not something I can edit. So I have to take into account that information. But then we know heart disease, for instance, largely comes from our lifestyle and environment. About 80% comes from non-genetic factors. And that's where epigenetics comes in. And looking at both of those simultaneously gives us an idea of who this person is and why they may be at higher risk, even though their cholesterol may not be as high, or they may not smoke as much. But why are they being flagged as being at higher risk? And taking all of that information into context is necessary. And what we say is, let's go to actually where the biology happens. The biology doesn't happen at lipid or hemoglobin A1C or blood pressure. The biology happens at the molecular cellular level. There's nothing more unique to each of us than our DNA. And so we're taking your genetics. Why not take our lifestyle and environment in the form of epigenetic markers? And that really what allows our technology to work well is a high quality of the information content that is not biased already, or is not 2 or 3 steps removed from where the biology is happening.
And you guys did act, and again, complimenting you guys maybe just a little bit, but you used cardiac events in your study, right? Like you did not use markers of events. Meaning, exactly. Oh, well, they had 70% blockage on their angiogram, or it correlated well with angiogram results. It's like, well, but angiogram results don't correlate that well with, and so by going all the way to, hey, actually, we validated this with real events, and we were able to tell, we were able to predict, and then we were able to predict change, now we're building quite a case. And I think that's something I always caution my patients is, well, did they test events? Did they actually test heart attacks or death? Or did they just test some, I see this all the time is, fiber reduces your risk of heart disease. And then you read the study and it just lowers your cholesterol. And I'm like, well, you made quite a leap there, right? That's not a one-to-one correlation. So I did appreciate that in reading your studies. Do you guys have any other, maybe you can't speak to that, so pre-publication bias, but do you guys have anything else in the pipeway on statins or management or other interventions that kind of show, hey, actually we intervened and then there was a reduction?
I guess the short answer would be yes, either in pipeline
yes or, no.
or planning. Okay. Yes.
Okay.
They're at various stages, but yes. And I think for us, that's the next evolution of being able to realize the full potential of this test. It's one thing to show the initial studies, and it's one thing to, it's a huge step to take it and deploy it clinically. It's another step to say, how can we continue to leverage the information? Because there's so much information there, and it's such personalized information. So it's a natural evolution of what we're doing.
Yes, and I think in the way we view it is a partnership. We make this as a partnership with clinicians. Cardio Diagnostic is not caring for the patients. Cardio Diagnostic is there to assist those in the trenches, those in the front line that have to deal with the day-to-day, I would say, toll of confronting the clinical realities that patients face. We're there to help them better measure their patient's risk and assess possible therapeutic responses. And we're going to continue to evolve to find better ways of measuring and better ways of displaying that information for clinicians that truly wish to be the leaders in the therapeutic community.
Mm-hmm. I think and that's why I'm so excited about, certainly I have done so many, I even have, talked to many patients about, statins, for instance. There's a lot of skepticism about statins. I do think they have their, secondary prevention data is a lot better than primary, right? So it's not that there's no place for them, but figuring out where that place is really tricky. I mean, do you do the LDL particle counts? Do you, total cholesterol, or total to HDL ratio, or, just using the AHA calculator seems to give a significant overestimate. There doesn't seem to be a good answer. And so the opportunity to have a good answer, I think, is very exciting.
Yeah, that's exactly it. And I think statins are, very much, they took us the first step on the journey to better healthcare. Mm-hmm. But clearly that isn't the path behind us. The path forward is with personalized precision medicine approaches, using AI to help us understand the complexity of information. Yeah, yes, there'll be some clinicians who are very slow to adapt, and my hope is that we find a way to communicate with these clinicians, because realistically, as our duty is to the patients, as we're both in the healthcare, all of us are in the healthcare industry. We want what's best for our patients. So for clinicians that find the information challenging, let us know. Talk with we have some wonderful outreach counselors who are specialized in explaining, some of these, at first glance, difficult technologies, and reduce them to concrete mechanisms through which patients can live longer, healthier lives. And at the end of the day, that's the best business model there is.
Absolutely. Yeah. I mean, and so before, and I do want to ask actually about the two tests here in just a second, but I did also want to say my own personal bias on some level is I feel like I get a lot of questions from patients who are doing the Joe Rogan thing, and they ask me about this test and that test, and mostly I poo-poo everything, and I'm like, that's nonsense. There's no data on that. That doesn't show anything. This is made up, whatever mushroom it is. And and so I feel like I get a little bit of I feel like I want to be at the cutting edge, and yet the cutting edge does not have any science behind it, or the so-called cutting edge, right? And so to find the real cutting edge and be like, look, when there is science, I'm happy to get on board early, but that's a big if, I think, a lot of the time. So maybe you guys can just go into now, as we move far away from the wizard and cat, maybe you guys can tell us about the two tests, what they are, how they're different, and maybe a little bit about how they work.
It's funny because I have to say something about Joe Rogan, if you don't mind. I'm a huge UFC
please.
fan, so I love Joe Rogan in the context of UFC. not
I
not
love his
so much in
podcast
all
too.
the medical.
Sure. I love his podcast too. I think I'm also sensitive, by the way, to the fact that, so many clinicians still are using total cholesterol as a guide for how to prescribe statins, which we know is not correct. And so then it becomes a question, well, I know my doctor is wrong, but now I don't necessarily have the science background to figure out who's right or how to go about evaluating studies. And so then you start speculating because there isn't that level of trust. And so I'm sympathetic to the problem. I think a lot of clinicians are pretty far behind.
And how many patients we know have the time and ability to go through and even understand, to be able to meaningfully challenge or ask their provider's question about why you're looking at total cholesterol. And I think that in itself is a whole other thing. But one of the things I think for us was pretty eye-opening was we found that, for instance, with total cholesterol specifically, 67% of people who had a heart attack within 3 years had normal total cholesterol. And I mean, that in itself was like, okay, if we're basing our decision on such data, like where are we going wrong? Like, not the decision, but the kinds of data that we're using to be able to make those decisions. But going back to your question about our products, as I pointed out, we started with coronary heart disease because it is the most common type of heart disease and the main cause of heart attacks. And so for us, it was an opportunity to address as the largest possible group when we were thinking about prevention and early detection. Because at the end of the day, where we come from is there's an opportunity to continue to prevent heart disease at different stages, whether it's, ideally before signs and symptoms, or even after you have signs and symptoms, there's still an opportunity to prevent an event. And so we found ourselves in a place where we looked at coronary heart disease and we said, there are people before the signs and symptoms. So they may already have risk factors, comorbidities, they may already be taking some medications, but they've not quite crossed over that first line of having signs and symptoms. And that's where our first test was developed. It's a 3-year coronary heart disease risk assessment. So it's meant for everyone who don't have signs or symptoms. Let's think about early primary prevention. Despite having risk factors, let's not cross that line of starting to have signs and symptoms. Although we know many people who have heart disease who's walking around don't have signs or symptoms, but the idea is let's look at the risk and see whether we need to intervene sooner rather than later. But then we heard from many patients who said, I need a test because I have signs and symptoms. I can't get in for weeks, if not months, to see my provider, to run on a treadmill. And one patient reached out and said, my doctor would not even order a coronary calcium screen for me. I need this test. So we realized that the next opportunity is for those people who may or may not have signs or symptoms, but are walking around with coronary heart disease that is yet to be diagnosed or detected. And so we developed our second test, Precision CHD, for the detection of coronary heart disease. So as opposed to 3-year risk, do I have coronary heart disease today? And so those are the two tests we currently have on the market.
So actually, I'll grill you a little bit on this. So
yes, please.
I'll admit I have a bias against the coronary calcium score, particularly for this reason, I guess, because again, I've seen data correlating with angiographic blockage, but not necessarily risk of mortality, risk of new events, and so maybe you can speak to a little bit I also wouldn't order a coronary calcium score. I'd order a stress echo or a CPET test, but maybe you can speak to the difference there between the predictivity, because it is in the causal pathway, or what's the difference between this and maybe a coronary calcium score?
So one of the key things with, and I'll let Rob talk to the spectrum of coronary heart disease, because I think that's truly the value of precision CHD, is all coronary heart disease is not the same, and all coronary heart disease is not obstructive in nature. And that's truly the main differentiator with our tests. And Rob can talk to the spectrum really, really well. But one other thing I'll point before Rob jumps in is, for us, innovating on the technology was one dimension, right? Like, we saw an opportunity from a science and technology to innovate and to offer something new in the clinical care to change the paradigm. But one of the other things we've learned, especially, COVID, of all the negatives, I think certain positive things emerge, and that is clinical care needs to meet patients where they are. They need to be tailored for patients where they are, and clinical care is moving away from traditional ways of care of coming in person and, scheduling an appointment. And so for
Absolutely.
us, we also saw the opportunity to innovate from a care delivery standpoint, which is why we offer a version that is also fully remote. So nothing against coronary calcium per se, but more so the idea of, can we cut to the chase and get people tested today because they need immediate attention, instead of waiting weeks, if not months, for them to go in to run on a treadmill. But Rob, to you on the spectrum.
Yeah, the coronary calcium is a valuable tool. But once again, it is just a tool. And I think one of the things that we have to realize, what it is a very appealing tool to clinicians, because it feeds into our understanding, our last decade's understanding of heart disease. In other words, you have high cholesterol, you develop plaques. These plaques obstruct the coronary artery, and you have a heart attack. Well, that's true for many people. But unfortunately, particularly for women, they have non-obstructive heart disease, and it can be equally deadly. And what the in silico approach that we used for our data mining didn't use the coronary calcium. What we really question is, did you have a heart attack? Did you have a coronary artery disease event? And we used that. And so, yes, surprisingly, many of the pathways we have map to those traditional, cholesterol, lipid pathways. But others map to the inflammatory diseases, are pathways that we know are important in inflammatory illnesses such as coronary artery disease, and are particularly important in women. Our tool works equally well in men as it does in women. And as such, it is a welcome step forward to more equity in healthcare.
I think you nailed it there. I mean, and the terminology I use is storytelling versus evidence. And what I mean by that is, there's the story that you just laid out, that cholesterol builds up plaques, builds up obstruction, leads to heart attack. Fine and well, except that the ischemia trial, Courage, actually said, well, even if you have 70% blockage plus, it actually, stenting those lesions does not reduce your risk. So, well, then we must have misunderstood the story somewhere, because if that were the story, then stenting them open should have prevented future heart attacks. And the fact that it does not really challenges the conventional notion of what exactly is happening. And again, I think you guys have found sort of as you said, an atheoretical, observational understanding of how to predict and how to intervene. And that's what's really exciting to me.
And the other thing is that can you we don't treat coronary calciums. In other words, can you, the challenge is the existing generation of tools is always there for assessment. But what do we do after we assessment? Oh, we start a statin. What if my heart disease isn't caused by statin? We start a statin.
Right.
Okay. How do I know if I have heart disease? And they throw up their hands. Okay. Methylation is dynamic. We have shown previously with Epi plus Gen CHD that if you treat the driver of heart disease, your methylation score reverts back to the baseline. In other words, as you change, your risk for heart disease changes. Similarly, the methylation vectors inside the diagnostic test are similar dynamic. And we look forward to working with the cardiovascular community to help understand the relationship between successful treatment and changes in these indices. Because in the end, what we want is a successful outcome. But we're knowledgeable of that even after a heart attack, half the patients don't take their meds. Why? Well, I'm here to tell you as a patient, I don't like taking my meds, number one. And number two is those medications have side effects. And, some very real side effects. For instance, I developed a rare syndrome called Schomburg's disease as a result of my medication for hypertension. Yeah, so it got pretty nasty there for a little while. So, and people say that, some trials show that statins don't cause myalgia. Well, my mother begs to differ on that subject. So, sure. the treatment, the life in the trenches, when patients confront their mortality and the burden of successful treatment is challenging. And if we can get better tools that can sit there and say, yes, it looks like your patient's responding, keep going, or no, this looks like a dead end, we need to go to plan B. That is a straightforward, and that is something that you're never going to get with a coronary calcium. That is something you're never going to get with an MRI. That is something you're never going to get with an exercise treadmill.
Mm-hmm. Yeah, absolutely. I think my father's in the same boat as your mother, it sounds like, gets the myalgias, and the question is it worth it to continue? Because it is affecting quality of life, it is affecting mobility, it is affecting all these things. And so if he knew that this were absolutely reducing his risk of future events, he might tolerate the loss of quality of life, right? But what is the number needed to treat? 1 in 100 at best, 1 in 200. What's the absolute risk reduction there on broad primary prevention? It's not great. And so if we could get a better number, if it's like, hey, this has a 1 in 2 chance or a 1 in 1 chance, we know that this is actually reducing your risk. Well, he could make a much more informed decision about whether he wanted to tolerate those side effects or not, or if he wanted to pay the price for a PCSK9, right? Mm-hmm. It's also if he knew that was important, well, he might pay the cost, but the uncertainty means he doesn't know whether that's worth it.
And I think you hit the nail on the head, though. You got to pick the right patient. And one of the challenges with the pool cohort equation is it is very inexact. Epi plus Gen is the next forward to help clinicians pick the right patient.
And just so Epi plus Gen is the 3-year risk, and then the other is
precision CHD.
And precision CHD is do I have heart disease now?
Coronary heart disease now, yes.
Coronary heart disease. And what is the definition of coronary heart disease that you're using there? It's obstructive plus non-obstructive, or what's the?
So this is one of the beauties of this test. Okay, for instance, if you get an angiogram, all the angiogram picks up is obstructive heart disease. It does not pick up non-obstructive heart disease. So we had wizards with 3 different types of wands, to use your analogy.
Okay.
And the first wizard was from the Framingham Heart Study. And the Framingham Heart Study did symptomatic heart disease, okay? And using a very broad test. So some was obstructive, some was non-obstructive. Some patients were young, some were old. Some were male, some were female. The second cohort was the wizards from Intermountain. This sounds like Disney is going to, get us for infringement. No, but these are the world-renowned clinicians at Intermountain. Personally performed coronary angiograms on all these individuals to help us understand who had obstructive heart disease and who did not. And then third, the University of Iowa cohort featured patients who were admitted for cardiac disease and diagnosed with, whose diagnoses were confirmed from their hospitalization record. So they had very severe heart disease. 3 different wizards, 3 different definitions, 3 different spectrums of disease. And yet across that entire large tent of illness, the precision CHD worked sensitively to detect heart disease.
That's fascinating. I mean, it's certainly, going back to my previous analogy about a different culture that treats redheads differently or whatever, if you can do different data sets in different cultures, different populations, different geographic areas, eating patterns, all these things will vary naturally across geography. Be fun to go as far afield as you can and do something in Africa or something, but even across the US, those things will change. And if you have consistency, then again, that's a signal that you're on the causal pathway, right? You're not just associative, but more exactly causal.
And like I said, it's due to the advances in high-speed computation. I mean, Meesha has put together a tremendous team of engineers. There's this old joke about a man looking with a flashlight in a parking lot for his keys. And at the end of the punchline for the joke is, where did you lose your keys? Well, over there, but I'm looking here because there's light. The power of high-speed computation. Yep. I mean, I'm an old school physician. If you could search a database with Microsoft Excel, we would have had your cure decades ago. But unfortunately, when you're looking at tens of, if not hundreds of billions of data points, you have to have engineers who know how to not only ask the questions, but to structure the questions in a manner that can be asked repetitively, precisely, and the information gathered systematically. And Cardio Diagnostics is very, very proud of this tool. And I think when the field gets a chance to look at the manuscripts, examine the evidence, they will come to the same conclusion that precision CHD will be a vital tool for the assessment and management of cardiovascular disorders.
One of the things I might add there is, what led us down this path was the solid science foundation that we had in genetics and epigenetics. So we really understood the science of it really well. And we were one of the first groups to get our hands on genome-wide methylation data when Illumina came out with the array in 2010, 2011. Before then, when Rob and I were studying epigenetics, and we have publications out there, we looked at targeted genes that was already known. We weren't able to look at the wide array of methylation data across the genome and say, we're not making any assumptions. We're going to see what the data tells us. We weren't able to do that before the genome-wide arrays came out. And so at that point, when the arrays came out, it became a data problem. So to be able to take a science that we understood so deeply and so well, and now merging it with a tool, which is also what AI and ML is. I mean, AI and ML can't do anything if you don't have any domain or you don't have anything else to feed it and bring it together. And so for us, that really what led to our success is being able to take the domain knowledge and couple that with a very powerful tool that allowed us to say that we are confident in being able to understand signal associated with the condition. But while we're confident, might as well go validate it one, two, 3 times, because if we're so confident, we should be able to show it,
That's
lighting
right.
up time and time again. So we took a bet on ourselves, and we're very confident that the way we've built the technology would continue to help us build new clinical tools to address different conditions.
Absolutely. I think that you said it exactly right, is having the confidence that, no, we've got this right. I'm going to go submit this to a prospective sample of a new data set, and just see what the validation shows. And then if the test continues to perform as expected in a foreign data set, now we can start to say, well, okay, now we have some significant confidence. So I did want to ask a couple of other off-the-wall questions. Have you guys tried I don't know if you're familiar with penetration testing they use in security, where they try to deliberately fool things. Have you guys tried submitting, the same sample or the same patient from different arms where you guys aren't aware of it, or tried to hijack the test in different ways, make sure it's reliable, make sure that it gives you kind of like consistent answers? Have you done any stuff like that?
Funny you should ask, because that's actually part of CLIA requirements to set up the test. So for instance, same person
Wow, I
tested
did not realize that.
multiple times, same
Yep.
people tested across multiple days, different people testing the same sample. All of that is part of the validation to establish the test as an LDT. And which is why when a lot of people talk to us about LDTs, establishing them is pretty rigorous.
Sorry,
And you
LDT?
have
I'm not familiar.
laboratory developed tests.
Develop
So
test.
it's
Okay. Yep.
it's a designation of the test, and it's run in CLIA labs, so high complexity CLIA labs,
Yep.
and it's governed by CLIA regulations. And so you have to do all of that. And we do, for instance, dilute the sample as much as possible. Do we still get a signal? We put different probes together and we see if there's interference when we're trying to measure one of the signals with the presence of other assays as well, or other material. So these are all done as part of establishing the test as a clinical test.
And so then taking that a step further, and I'm just messing with you guys now at this point. I'm just curious, but like
You should.
yeah. So if if a patient comes in and says, "Oh yeah, doc, I stopped smoking," whatever, could I tell if they were not telling the truth with your test? Like, would there be is there a truth detection aspect to this, of whether they're taking their medicine or whether they stop smoking or they
I
exercise?
assure you, we can tell if they stop smoking.
Yes.
Okay, that's
Really,
pretty
really
good,
well.
right? I mean, that's
Yeah.
yeah,
Well,
yeah.
the funny thing is,
I mean,
the
that's
person that
actually
you start processing some of the initial data is the other person on this video, so she knows as well as anyone.
Yeah.
Yep.
I mean, that's actually pretty amazing. If you can really say that, hey, no, you didn't stop smoking, like, you're
Well,
you're telling some fibs
Well,
here.
like I said, is that there was just a very nice article that was just put out on the use of DNA methylation, sponsored by the National Institutes of Drug Abuse, published in Addiction Neuroscience. And I would really encourage, if people want to know how it's done, I would go take a look at that National Institutes of Health sponsored publication. This is the power of federally funded research infrastructure. It gives you quality products in a timely manner. And like I said, we're here because of the people of the United States funded this research, and it's our job and our commitment at Cardio Diagnostics to get this to them as quickly as possible.
That's phenomenal. Yeah, I mean, I think, again, that all speaks to reliability in some sense as well. And if, I don't know if you guys have done exercise testing, or like if someone is able to drop their risk from what you say was moderate, and I guess I'm speaking of and I'm getting the names here. The Epi plus Gen, I guess, is the 3-year prediction.
That's what happens when you get an engineer to name things.
I was gonna say, you guys might need a marketer to rename the test here. Just,
Precision CHD was from marketing. Epi plus Gen CHD.
Wow.
I'll take the not so great credit for it.
So the 3-year test here, if we reduce the risk from moderate to low, that does seem to, at least, in the smoking study, did seem to correlate to decreased events, as I understand it. Have you done that with other interventions? I mean, exercise in particular, I guess, was the one, or nutrition or weight loss or lifestyle type things?
Yeah, so those are the next set of studies. There's such a vast number of things we can test. And so for us, as Rob pointed out earlier in our conversation, it's about thinking about the partnership. What makes sense? Who are we partnering with? What are they interested in looking at? And also what we're interested in looking at, right? Like, that's part of the studies that we have planned and that are ongoing, is to see what are the different levers that we can pull and what are the significant changes we're seeing as a result of pulling those levers.
Yeah, and that's exactly
That's awesome.
Because people are going to take different pathways. For instance, if you want to reduce, as you well know, from treating hypertension, well, you can take, you can take your amiloride, you can take a different medication, you can lose weight, you can exercise. 3 different pathways. You would expect that the biological pathways would be measured differently, but all have the same outcome. And so we're looking for, there's going to, the number of studies, unfortunately, that we need to do are going to become greater rather than fewer. So I guess, like,
I can only imagine.
Exactly.
Well, the sign of a good finding is that it leads to many, many other findings. And I think this is only the first chapter in a long series of books on better cardiovascular care for the American public.
Absolutely. I mean, my mind already is racing. Obviously, being in the wellness space, there's all kinds of debates about vegan versus carnivore, and everything in between, versus fasting, prolonged fasting, intermittent. And we haven't had a way of answering that question, because you have to do mortality studies. So you have to basically you have to get people to do this versus a sham or versus another control for like 10 years before you can really. And so, trying to get nutrition science under control has been difficult because we've lacked a test. So the opportunity here is to say, well, we finally found a way to shorten the evaluation process by saying, well, if you switch to a carnivore diet, your lipids went up, but your cardiogen plus epigen went down or whatever. So maybe it is on track, and the lipids were just, a false flag in some sense. Or no, actually, despite the marketing of carnivore claims, your risk went up. And so maybe you need to change gears and go a different way, whatever the answer is, right? Or maybe it's individual. Maybe it's your genetics that make the difference.
And you said it, whatever the answer is. And the answer is what's right for the patient. And that's what we're continuing to conduct more studies to really understand. What does the patient want? Number one. Number two is, what's important to that patient? There's an old joke about the American Heart Association diet. You could follow it religiously, and you may not live longer, but it'll sure feel that way. At the end of the day, we want quality health care for our patients.
That's actually pretty good. I hadn't heard
that. And we're committed to work with clinicians to achieve that goal for their patients, no matter how their patients choose to be treated.
Mm-hmm.
That's phenomenal. So one last, and of course I'll open it up to you guys if you have more to say, but I saw that the numerical risk estimate the risk estimate is low, moderate, high on the report. Is that right? Is that a grouping of percentage outcomes? How does the AI actually output a percentage and then you guys group it, or does it output the low, moderate, high from the beginning?
Yeah, so one of the things we wanted to do with the test was we wanted to make sure that it was in a format where clinicians already understood what they were seeing. And so clinical guidelines calls for 4 categories: low, borderline, intermediate, and high. And they're defined by specific percentages, 0 to 2.5%, 2.5 to 5, 5 to, actually, I think 5 to 7.5, and then over 7.5 to 20 and 20 and above. Or actually, I think the first one is 0.5. Anyway, it is defined by clinical guidelines as the percentages. So we take what is outputted by our algorithm and map it to the clinical guidelines percentages, and that's how the buckets are finalized. But we also do provide in the same report the exact percentage. And in addition to that, one of the things we know about heart disease, of course, is there are 2 non-modifiable risk factors for heart disease: age and gender. We can't change those 2 things. And so for us, I should say sex, age and sex is what we can't modify. For us, one of the things we also wanted to know is, if I'm a 65-year-old female and I took the test and I had an 18% risk, is that indicative of me being a 65-year-old female? Because we know heart disease risk does go up over as you get older. And we know that women, perimenopausal, postmenopausal risk goes up. Is that a function of who I am, or is it a function of other things in my life with my lifestyle and environment? So we benchmark that person's risk percentage against their peers. So women who are similar age. So if they came up to be 15% on average risk and I'm at 18%, then we know I'm higher than my peers despite being a woman who's older and is already naturally at elevated risk. And so that gives my clinician additional information as to where I'm falling relative to my population. And now with actionable clinical intelligence, we're taking it a step further where we're saying we have these biomarkers that we've profiled for Meesha. What is her biomarker saying? Is it ranking a certain way? So is certain biomarker being the largest contributor to her risk? And if so, where does that marker map to? Is it mapping to diabetes, inflammation, lipid? And so now we've not just benchmarked this person, but we've given an idea of what might be driving this person's risk. And that's a way to say, how can we take more targeted steps for Meesha versus someone else?
And that's all included in the precision epi.
Both the tests have, yes.
Oh, both the tests. Okay, have that.
Both the tests
That's
have
phenomenal.
that information.
I think that's pretty amazing, and it is a 3-year now. Okay, so what about if I'm testing? Do you have guidelines on who can and can't be tested? If I'm testing 30-year-olds or I'm testing 25-year-olds?
Okay, absolutely. Okay, so first of all, you know, the test is configured for those over the age of 35. Number one, and number two is because that's where the data is most robust. Can we predict younger? Yes, we can.
Mm-hmm.
But we want to put out a quality product. So if we can't robustly predict, we're not going to provide it. Second is that you must not already have heart disease. This is a test for risk for heart disease. And the treatment guidelines think if you already have signs and symptomatic of heart disease, to be tested for heart disease itself. Obviously, is if you had major cardiac surgery, we don't want you to take the test either. So there are some things that you should not have before you take the test. But it is a standard heart disease screening test that can be used interchangeably with something like the pool cohort equation. And I think the real key here is that gets back to my mantra about picking the right patient. Okay? The challenge with the pool cohort equation is it misses so many heart attacks, specifically in women. And head-to-head testing, our test detected more than twice as many events for women. So, you know, realistically, for clinicians that take care of women, this is a no-brainer.
Mm-hmm.
Yep. And 35 is a pretty good cut. I mean, you know, I was joking about 30 and 25, but that's not my primary worry is cardiac disease in 25-year-olds, right? But 35 is a pretty decent cutoff to say, okay, hey, if you have even a slightly elevated risk at 35, maybe we need to be thinking hard. If your 3-year risk is anything other than low, right? then maybe we need to be thinking about
and that was one. And the team worked very, very hard to get that graphical output to the clinicians, because you're absolutely right. You have a lot of things to worry about with your patient, and you get about 7 minutes with them. And so the graphical output is specifically designed to rapidly communicate risk. So if you have to fish or cut bait, because your patients can have more than heart disease. You know, breast cancer, colon cancer, the common cold. Physicians have to quickly assess, communicate, and move along. And if we're hoping that their heart disease risk is low. If not, our tools will help give clinicians the guidance on how to move forward.
Yeah, that's been. I mean, I'm lucky. I have an hour per patient, so but I'm not the typical.
You're not the
physician.
typical.
I have, yeah. Well, that's phenomenal. I mean, I'm happy to open up the floor to you guys. Is there anything we didn't cover that you're excited to share?
Wow, we always tell people we can talk about cardio for days. So do we have time? No, just kidding.
I have lots of time. As I said, I give my patients an hour, so you guys get 2 hours between the two of you. Actually,
well, we're looking forward to meeting clinicians. I know that Meesha, that we're scheduled to go to Anaheim to meet with the major meeting of primary care physicians, and I'm certainly looking forward to that. And then you have an upcoming meeting here in New Orleans.
Yes, we're going to the nurse practitioner meeting in New Orleans in June. And for the primary care focused, I think it's PriMed West in Anaheim in July. And it's such a joy to be able to meet the people on the ground who are doing patient care. Because, one of the things I think we were very fortunate, especially with Rob being a clinician, is we didn't have to build in silo. We were always able to use feedback in real time from clinicians and other clinicians that we work with to continue to adopt the product. And, believe it or not, the actionable clinical intelligence is a newer extension of the report itself, because clinicians constantly asked us, we need that additional information to take that next step in addition to telling us the risk. Like, how can we understand these biomarkers, where they map to, what do they mean? And so we built ACI as a part of that feedback that we were constantly getting. So going to these conferences, meeting people who are doing patient care and being able to partner with clinicians, I think that's truly the joy of continuing to build cardio.
And like I said, and it'll be great. We constantly hear that clinicians are frustrated, waiting 4 weeks, 6 weeks. Here, just mail us the tube overnight. We'll, test it, turn it around, get you the results back within the week. So you can take care of your patient. And eventually we're hoping for a same day solution. Imagine coming into your doctor's office in the morning and getting the answer in a phone call in the afternoon with the prescription or, the suggestion for your therapy, by evening. That's the kind of, progress that we expect to make at Cardio Diagnostics here over the next couple of years. And it's exciting. And we look forward to working with you and your viewers to move this process forward.
Absolutely.
Yeah.
And so along those lines, the test is available now, and do they have to go through their clinician? Do they have to? What should patients who are interested in getting this test do, other than lobbying their clinician?
2 options. Actually, we have the test integrated with a telemedicine provider for the very reason that we want to democratize healthcare. We want to bring it to as many people as possible. But you can get it through your clinicians as well. So if you get it through the telemedicine provider, we send a Lancet-based kit to your house to be able to collect your sample and send it in. Everything is included in the kit. But if you're seeing your provider and you want to get your sample collected in the office, we can accommodate that as well. We have a Vacutainer-based kit that we will send over, and you'd be able to draw a blood sample. So either way, the whole goal is, how can we think about accessibility and flexibility in delivering care?
Is there any difference in accuracy between the Lancet kit and the venipuncture?
No, they're actually, the tube is exactly the same. It's manufactured by Becton Dickinson. It's just one is a small one is a larger one. It's the exact same company, exact same tube. And the nice thing is what we do is based on PCR methods, which amplify DNA. So as long as, one of the things DNA doesn't, we're able to process it a couple of days later, but what we do is we get people to send an overnight sample. So everything's included, including shipping is included in the kit. So the lab gets it overnight and processes it right away, because we want to make sure that the DNA is of highest quality and we're turning around high quality data.
That's awesome. And cost, what's the cost and coverage? Those are, I guess, other questions. Not for my patients, we'll all pick cash and fine, but for other people watching.
The test is currently not covered by providers. We do FSA and HSA, especially if you're going through the telemedicine platform. So that's accepted. EpiPlus Gen CHD is $350. Precision CHD is $849.
That's actually quite reasonable overall. I mean, I think you'd get a lot of takers on it, at least in I have a bias sample.
Well, for the leading killer in the United States, I think it's a considerable step forward. Because if you think the test is expensive, just think how much the hospital bill will be.
Yep. Well, and I mean, even compared to other less effective, just getting a non-stress echo, I think, is running people $400+ and that wouldn't tell you anything. It'll tell you, CHF or other things, but it wouldn't tell you anything.
Much
about
lower sensitivity. Much lower sensitivity.
Yeah.
Well, phenomenal. I really appreciate you guys taking the time
Thank you
to
for
talk to
having
us.
us.
And yeah, super exciting time.
Stay in touch.
Thank you so much. Yeah, take care.